Be inspired, supported, and empowered. This is the Global Healthy Living Foundation podcast network.
Whether we like the term medication overuse headache or we like the older term, we can see it, we can smell it, and we need to diagnose it.
Hello and welcome to Talking Head Pain, the podcast that confronts head pain head on. I'm Joe Coe, Director of Education and Digital Strategy at the Global Healthy Living Foundation and a migraine patient for over 20 years. This is a second part of a two-part interview with Dr. Alan Rapoport. He is the Clinical Professor of Neurology at UCLA, the past president of the International Headache Society, and the co-founder and CEO of BonTriage, a healthcare company that helps people better understand their chronic disease. In this episode, we will be discussing a very important topic that concerns many patients, medication overuse headache. The topic that I want to talk about now with you is medication overuse headache. Can you explain that term and why patients should know about it?
Well, one of the biggest problems that we have with our headache patients is those that have chronic headaches and are always in pain and are trying to feel better, end up taking sometimes more acute care medication than they should, whether it's over-the-counter medicine, whether it's a triptan, whether it's some of the newer medicines that work on CGRP, or even in some cases a butalbital-containing medicine like Furanol or Furacet, which I don't use anymore, or in some cases even opiates, which I definitely don't use anymore. And it turns out that if a patient takes that too frequently, and that is hard to know exactly where, but we're thinking more than 2 to 3 days a week on a regular basis, that it actually makes headaches more frequent, more severe, and more disabling. And that's a very hard concept for the patients to understand, even if it's explained appropriately to them. And sometimes they just don't want to accept it. But once the doctor understands that, and the patient understands that even though they're trying to make themselves feel better, they're actually doing something that may make them worse. And there's a plan put forward to improve upon that and get rid of what we currently call medication overuse headache. Once that happens, we've got a good chance of making the patient better. Without accepting the fact that it occurs and doing something about it, we have not a very good chance of helping the patient.
So in other words, if someone's using medication too much, you would work with them to find a different treatment protocol to make sure that they don't need to use the medication that much.
Exactly. And it could be as simple as, I only want you to use it 2 days a week. And on the other 2 days, if you need something, we're going to get relaxation techniques for you, or we're going to get you a device that works in a different way. Or, and this is what we do much of the time, we're going to put you on a preventive medicine that you take either every day or every other day, or an injection once a month or every 3 months. And that preventive medicine will decrease the number of headaches you're having, and then you won't need to take the acute care medicine so frequently. But whatever the answer is, we will work with the patient to figure it out so they can get out of this medication overuse headache. Because if we can't get them out of that, it's very hard to make them better. I'll give you one example. A very good patient of mine who was almost 70 when I first saw her was using sumatriptan 26 days a month. And I said to her when I first met her, do you know why you have so many headaches? And she said, well, I know you're going to tell me I have medication overuse headache. So have 3 other doctors, but they couldn't help me. I said, well, did you ever decrease the number of sumatriptan days that you had in a month? And she said, no, I couldn't, because if I don't take it when I need it, my headache gets unbelievably severe and may stay that way for 2 weeks. So I can't do that. And I said, well, I'm going to try everything I know to get you better, but I'm going to warn you right now, I may fail only because a big part of the problem is the number of days you take sumatriptan. And bottom line was, I did fail until some new drugs came along, preventive drugs. And once she started to take them, the headaches went down in number. And she said, I didn't need to take them. Great. But not everybody is as lucky as she is.
And I think what is important to underscore here is that it's a really hard cycle to break. And you need to work with the right physician. And the experience that you just shared is a powerful example of that. People, patients, people like me need to know that we have a partner in our care, that we're not being judged for using the medication, that this woman in this case felt that she needed to not have a 2-week long migraine, but that in reality, there are probably ways to optimize our care that could reduce that frequency. And like you said, prevention medication sounded like the right way for her to go. So I think that's really important to understand that when we're talking about concepts like medication overuse headache, that it's not about blaming the patient. It's about really figuring out as a patient, as a provider, using shared decision making to understand what our goals are, the lives that we want to live, and how we can optimize our care. And I think that's a great example.
You're absolutely right. And the average doctor, if that doctor was smart enough to know about medication overuse headache, might say to the patient, you come back in a month on no sumatriptan and let's see how you're doing. That's not adequate care. The patient's going to leave and never come back because they can't do that. And at least if the doctor said, okay, do this instead, it would be helpful. So you're right. Without a partnership, there's no chance you can help a patient like that.
And I really appreciated a simple thing that you said, and I may fail as the provider, you being upfront with the patient, that you're not failing the patient, the medication's failing the patient, and that you guys working together might fail. And you're taking ownership and responsibility of that, I think is a really powerful shift that we don't hear a lot from providers. So I appreciate that you said that.
You know, it's difficult to go into headache medicine as a physician because patients are in a lot of pain and a lot of disability, and we can't always help them immediately. And it's very tough on doctors and nurses dealing with headache patients a lot. And it takes a certain type of person and personality to go into that field. And for whatever reason, I love it. And I love helping patients. And I struggle with the patient. And I say to them, I will stick with you. And I might say, not, I might fail. Maybe it's more appropriate. We might not get to where we want to get right away. It might take us several months of trial and error and changing doses and medicine, but we'll work together. Most doctors don't want to do that, to be honest about it. They don't have the time. They don't feel they're being compensated enough anyway, and these patients might call too much. So a lot of doctors just don't want to deal with headache patients. So you're right. Patients need to find the right doctor for them.
Totally agree. And that is a good shift for my next question. You've been talking a lot about patients. What would you want your colleagues in neurology to know, and even primary care physicians or nurse practitioners, about medication overuse headache?
Great question. Hard to answer in less than the 2 hours that we have, but I will take a stab at it. First and foremost, we have to make the diagnosis, whether we like the term MOH, medication overuse headache, or we like the older term rebound headache, or there's a better term out there that we haven't quite settled on yet. Whatever it is, we know what it is, we can see it, we can smell it, and we need to diagnose it. And that takes education because, believe it or not, there are a lot of doctors and nurses that don't know what that is. They've never heard the term. They don't understand it, let alone know how to treat it. So we have to make the diagnosis better, and you talking about it a lot, writing about it a lot, me writing about it a lot, talking about that. We're just about to submit a paper on medication overuse headache to a prominent journal and talk about how to diagnose it and some ways to treat it. And more research, clinical research has to be done because we believe that the newer drugs that work on CGRP and block it in some way are so powerful that it really helps to treat medication overuse headache, but it hasn't been proven yet. We see signs of that in the trials that were done just to get them approved for treating migraine. And we see that patients that come into these trials with medication overuse headache, when their migraine is successfully treated, the medication overuse headache tends to go away. But it wasn't a trial for treatment of medication overuse headache, so it's not good enough yet. So we need more trials. We need to convince the companies that have these very good drugs that they need to study it. And then we really need to educate the doctors about how to treat it. So it's simple. Everyone needs to make the diagnosis, doctor and patient, and both of them need to work together to use the right drugs or the right techniques, if it's not just drugs, to get the patient better. And I will say this, for all those years that I've been practicing as a headache specialist, I struggled tremendously because I didn't have the right preventive drugs. I had some preventive drugs, but they didn't always work in medication overuse headache. So my job was to convince the patient to use fewer acute care medicine pills in the month and take these preventives, some of which had side effects. Very, very, very hard to do. Now I have a reasonable chance of saying to a patient, I'm going to give you this pill once a day or once every other day. Or I'm going to give you this shot once a month or once every 3 months. And you will probably have fewer headaches, and then you should use fewer of these acute care medicines. It's like a whole new world for me. What I used to struggle with has gotten easier for me and better for my patients. Now, not everybody knows what I do about it. So that's the problem. We need to educate the doctors and the patients.
Yeah, it's really interesting. This is a separate topic, but I think there's an inverse of this as well. And I'm thinking about my experience as a patient. The older medications before the CGRPs came out would make me feel so bad that I wouldn't take them and treat my migraine attacks as often as I should. And I was under treating, and I think people have this problem as well, that you undertreat migraine attacks because of the side effects and all these things. So there's an inverse of that with some of these medications that it made people feel worse. I certainly did. It was hit or miss. Sometimes it worked well to stop the attack. Other times it made me feel worse than the attack. So I would sit there with the medication, the nasal spray or the injection, and think, is this worth it? The risk of feeling worse because I might feel better. And now that there's all these other options, I'm in a much better place, which is just amazing that science is there.
A couple of statistics that are pretty shocking. In the old days, if I put somebody on a triptan, I would have a higher percentage than what I'm going to tell you because I stuck very close to my patients and they could get in touch with me all the time and so on. But if the average doctor put a patient on a triptan, the number of people still taking that triptan at 6 months is 25%. It's unbelievable. And worse than that, in the old days, you put somebody on an epilepsy medicine as a preventive, a beta blocker as a preventive, an antidepressant as a preventive. The chance that the drug I put them on, that they'll still be taking it in a year, something like 16% of them will still be taking it. So patients aren't stupid. They know that they feel terrible on these drugs. They're not even sure they're working, so they don't take them. The only way a headache specialist can do better is if they really interact with their patients on a regular basis. And if somebody calls me and says, I'm getting these side effects, I know either to lower the drug or to change to another one. When you can't get your doctor, you stop the drug. And by the way, I have that experience. I can't get my doctor on the phone either. I don't have migraine, but I can't get my general doctor on the phone. I have to go on my chart, and if I'm lucky, somebody will answer me. It's difficult today.
Really is. And general practitioners are doing the best that they can. And I know that my primary care doctor managed my migraine for probably 15 plus years. And I was on a medication that I ultimately shouldn't have been on. And it was causing things that I didn't even realize until I was passing out. And people were like, why are you passing out? And, oh, your heart rate's 35, 40. That's not normal. Uh,
I know
so
what medicine you are on.
I know you do. And it's mind-blowing how much that impacted my life, and I didn't realize how much it was impacting my life until we worked to getting off of that and onto different types of treatments. And many of us, and this is not a unique experience, have cycled through all of those drugs. And unfortunately, we have to, and you know this because of the way the insurance companies operate, that they force us into step therapy and utilization management techniques that really harm us. And we have to take medication that wasn't developed for our disease before they approve the medications that were developed for our disease. It really is mind-blowing if you take a step back and look at it that way, but it's why we have great providers and physicians like you that are pushing that and talking about these issues.
Well, I think we should remind physicians and nurses we shouldn't give in to those insurance companies. It's because we do that situation you just described exists. I know it's difficult to fight them, but if we all fought them as doctors, nurses, and patients, they'd have to give in, and we don't. And we accept horrible treatment dictated by inexperienced people in front of a computer for an insurance company just so their bosses could make a lot of money. That's really what it amounts to. And it's wrong.
Tell us how you really feel about that. It is wrong. It's
You know,
horrible.
I don't think it's legal for me to say that on the air. If we're on the air.
M- it's
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 horrible.
disgusting.
It's horrible. And I fight it, but you know what it takes? My blood pressure goes up. I have to call a doctor on the phone. When I call, they say, he's busy right now. When they call me back, I got a patient on the exam table. So I have to say to the patient, excuse me, I need to speak to this insurance company for 5 minutes, and I would do the same for you. I talk to them and I start by saying, well, Dr. So-and-so, what is your specialty? And they say, I'm a retired gynecologist. And I say, well, I'm a professor of neurology and my field is headache. And let me tell you why I need this drug. And 9 times out of 10, and I'm not mad at them, I'm just explaining, 9 times out of 10, they'll go along with me. But most doctors won't pick up the phone because they lose money when they pick up the phone. It aggravates us. I once made one of those calls from the hospital, from my office in the hospital at Greenwich Hospital in Connecticut. And the nurses came running in. Dr. Rapoport, are you okay? I said, why? I said, you've been screaming for the last 5 minutes. So, it's horrible what happened, but it is that way and we have to fight it. That's all I can say. And I've been fighting it for years and it probably hasn't been helpful, except to my patients.
And that really matters to that person. So that work is super important. People are getting the treatment that they need if they're seeing you, which is really amazing. And it should be the standard across the board.
The last thing I'll say about it is the last time I did it, because I don't do it that much anymore. The last time I did it was about 3 months ago. And I set a stopwatch. 40 minutes. Some doctors see 3 patients in 40 minutes, So it's really horrible what's happening.
And they do it because it works. It wears down the
It
physician, it
works.
wears down the patient. We're tired.
And they're making a lot of money on this.
One last question. We talked about this a little before we got on air. I know that there's some evolving language around the term medication overuse headache, and you mentioned it used to be called rebound headache. Now it's medication overuse headache, and that's how researchers and many clinicians are using and defining it. And I'm hearing in some of the patient community a term called medication adaptation headache. And the logic behind that, from my understanding, is that we want to make sure that patients don't feel blamed for using medication that we feel we need to use. So have you bumped into that term, and what do you feel about the spirit of these language shifts?
The answer is I haven't bumped into it too much. I guess my patients haven't been informing me, although I do go to meetings where I hear what's happening with patients, but I haven't run into it too much. I agree completely with the reason for coming up with another name. I always say to my patients, you're taking more medicine than I would like you to take. And I know you're doing it because you're hurting and you're trying to make yourself feel better. But I want you to understand that you're actually possibly making yourself feel worse. So whatever you want to call it is fine with me. But I have to use that term because of insurance again and the companies and when we do research on an international basis, we need everybody kind of talking about the same thing. So that's the term that we're all using. I was very involved in the International Headaches Society, but I was not on that particular committee that picked that term. I don't particularly like the term, but it's there. And until it gets changed, we have to deal with it. I'm fine with a patient asking me, can we use a different term? I'm fine with it. And I just explained to them, I need to use the correct term when I make a diagnosis. And somebody may look over all the charts one day and do some research, and I want to use the correct terminology. But I completely agree with the reason for wanting to change the name, and anything is acceptable to me. And I hope some patient will come up with the perfect name for it, and I will adopt it immediately.
Amazing. That's a really good way to look at it. The disease is personal. There's large discussions over migraine versus migraines and migraineur and person living with migraine and we can get really bogged down by it. And it's a really important discussions, but also it's like, how do we get the treatment and the care that we need? And how do we cut through the noise to get it? And I just wanted to make sure that for those of us that prefer one term or another, that we addressed it. And I think that you addressed it really well. Was there anything that I didn't ask that you would want me to?
We do need really good research, and then we need the companies to say, okay, now we have the data, so we can apply to the FDA to get approval for treatment of medication overuse headache, because it's a big problem. And about headache in general, there's so many things I could say. I would simply say we're in a good spot right now, and it's very important that patients find the right doctor or institute to be treated at, and that's very difficult to do. So patients should keep looking for online stuff and podcasts and the kind of work that you do to spread the word. And I'm glad to help with any of it, because until we have patients that can really control their headaches, we haven't done a good enough job.
Thank you so much for joining me today. I know that you're busy and your expertise is really valued for both me personally and our community at large. So thank you so much for joining me on Talking Head Pain.
Well, I'm very happy to have been here and to help spread the word a little bit. And thank you for being so insightful about asking the right questions.
Thank you for listening to the second part of our two-part interview with Dr. Rapoport. If you haven't yet, check out the first part where we discuss Dr. Rapoport's career as a headache specialist and take a look at how far migraine treatment has come.
Be inspired, supported, and empowered. This is the Global Healthy Living Foundation podcast network.